Last time, we looked at the human impact of health disparities on African American and Hispanic populations. Now, we will be digging deeper into the social structure that has caused and perpetuated such inequity. From our prior research, we learned that predominantly African American communities have a 3 times higher transmission rate than majority white counties, and Hispanics and Latinx individuals are 1.5 times more likely to contract COVID than whites. African Americans are 2.5 times more likely to be hospitalized for COVID than whites, and 1.7 times more likely to die. Hispanics and Latinx individuals are 2.4 times more likely to be hospitalized for COVID than whites, and 1.9 times more likely to die. But why? There is little to no evidence that suggests that certain races and ethnicities are more susceptible to contracting COVID or experiencing severe symptoms due to their biological makeup. And, at the beginning of the pandemic, there were a lot of stigmas surrounding contracting COVID and people associated infection with poor decision-making. In actuality, there are a myriad of factors beyond one's control that can increase the chances of becoming ill. Racial disparities regarding the COVID-19 pandemic are structural, as opposed to biological and individual. When we examine the factors influencing the disparities in access and care for Blacks and Hispanics regarding the COVID-19 pandemic, we see that an overall structural issue develops due to prior poor social determinants of health and overrepresentation in higher-risk living situations and occupations. Written and unwritten rules, individuals' relations with others, and incorrect representations of racial groups act as forces that drive these disproportionate transmission and severe infection rates.
African Americans are more likely than any other racial/ethnic group to get coronavirus disease, be hospitalized for it, and die as a result of it. Psychosocial, cultural, and environmental vulnerabilities, together with pre-existing health issues, increase this health inequality. Many health metrics have been used to examine inequalities across racial/ethnic groups, and health researchers have recently advanced concepts of health equity and socioeconomic determinants. Looking back to the mid-20th century, the U.S. government decided that African Americans were considerably more likely than non-Hispanic white Americans to have a variety of diseases, such as type 2 diabetes, asthma, end-stage renal disease, and cardiovascular disease. Adult obesity rates for African Americans are higher than those of whites in nearly every state of the nation. 37% of men and nearly 50% of women are obese. African Americans have higher rates of diabetes, hypertension, and heart disease than any other group. Asthma prevalence is also highest among Blacks. These issues contribute to exacerbating COVID-19 symptoms and places African Americans in disadvantages when it comes to recovering from COVID-19. When analyzing the deaths, doctors have implied that a person's risk of severe illness from COVID-19 increases as the number of underlying conditions they have increases. While looking at the social determinants of health that affect African Americans, many of the issues stem from socioeconomic issues. Economists use the Gini coefficient to measure income inequality between non-Hispanic white people and racial/ethnic minority populations. The values range from 0 to 1, with the higher values representing greater income inequality. From 1990 to 2018, the Gini coefficient in the United States rose from 0.43 to 0.49, showing an increase in income inequality. When income inequality exists along with other disparities, health insurance, and access to quality health care, public health pandemics marginalize racial/ethnic minority groups. Members of racial and minority ethnic groups are more likely to encounter barriers to getting care, such as lack of health insurance. According to the CDC, only about 6% of non-Hispanic white people were uninsured, while the rate was 10% for non-Hispanic Black people.
Like African Americans, Hispanics and Latinx individuals had overall worse health than whites before the pandemic. As of 2015, according to the CDC, Hispanics are 23% more likely to be obese than a non-Hispanic white person. While non-Hispanic whites are more likely to have blood pressure issues, Hispanic individuals are 24% more likely to have poorly controlled high blood pressure. Hispanics also have a 50% higher death rate from diabetes than whites. These 3 health issues have all been proven to exacerbate COVID-19 symptoms among individuals and decrease their chance of survival. These pre-existing health disparities can in part be explained by poor levels of social determinants of health. It is no secret that Hispanics are socioeconomically disadvantaged when compared to whites. While researchers find Hispanics to have lower overall mortality rates than whites, a Hispanic mortality paradox has been uncovered, suggesting that Hispanic health would be more favorable and mortality would be lower if Hispanics had comparable levels of SES as whites. Further, researchers have found that U.S.-born Hispanics experience greater and more frequent environmental stress than whites, which suppresses their immune system and ability to prevent and fight disease, decreasing their lifespan and the overall quality of it.
African Americans face homelessness and incarceration at rates higher than other races in the United States. Reiterating what I said in Project 1, although constituting only 13% of the U.S. population, African Americans account for almost 40% of the country's homeless. Many homeless people live in close quarters, have compromised immune systems, and are elderly, making them especially vulnerable to infections such as coronavirus. When we fail to provide the unhoused with the resources and care they need to be healthy, we are perpetuating a system that ignores individuals who are helpless to change their housing status. Finally, African Americans are overrepresented in U.S. jails and prisons. There has been minimal response to stopping viral transmission within detention institutions, which are unable to provide the physical separation required to successfully contain COVID-19.
Because African Americans, Hispanics, and Latinx people are overrepresented in frontline and lower status occupations with less access to proper protective equipment, they are at a higher risk for COVID contraction than their white peers who can work from home. In order to get paid, these people must go to work. They face a difficult choice: protect themselves and those they live with from the virus that is killing people of their race at a disproportionate rate, or lose their job and steady source of income that is already insufficient at providing for their family's needs. At-will employment and anti-union laws are also act in constraint of the individual by failing to protect the employee and decreasing their level of power. This lack of protection forces the individual into an unsafe environment that risks their health and, in turn, their families. Now that we understand some of the mechanisms behind increased transmission and infection rates among these groups, we can begin to look at why they are not receiving proper medical attention and sufficient care.
African Americans are less likely to receive adequate care than compared to their white counterparts. The National Academy of Medicine says providers are less likely to deliver effective treatments to people of color when compared to their white counterparts, even after controlling for characteristics like class, health, behaviors, comorbidities, and access to health insurance and healthcare services. 1 in 5 Black adults said that they were treated unfairly because of their race in the past year when getting health care for themselves or a family member. A startling 37% of Black women with children report this type of discrimination, compared with 25% of Black women overall, and 15% of Black men. Comparing to the white population, 7% of white women and 4% of white men have said this. This distrust pertaining to the healthcare industry has people refusing to go to the doctor to receive the care they need.
Hispanics and Latinx individuals are less likely to see a doctor when they are sick due to poor past experiences that have left them with a negative impression of medical professionals. Almost 3 in 10 Hispanics indicate they have a communication problem with health providers, and 2 in 10 Hispanics say they have difficulty in getting care because of their race or ethnicity. This lack of trust can cause unnecessary severity and mortality regarding COVID-19 infections. Also, Hispanic and Latinx people make up a disproportionate fraction of metropolitan populations where COVID-19 has increased unemployment the most. At the beginning of the pandemic, Hispanic and Latinx unemployment surpassed Black unemployment rates, and at the end of 2020 remained higher than pre-pandemic averages. As a result of these heightened levels of unemployment, families who already have lower incomes are even less able to afford health insurance, as there is a lack of sufficient healthcare funds allocated to Hispanic and Latinx individuals. They received the lowest amount of healthcare funding in relation to the proportion of the population that they make up: 18% of the population and 11% of funding.
We can learn from Eastwood and Smith that social structures shape access to many types of resources. Because of how social systems allocate resources, some people may benefit while others suffer as a result. In terms of our project, Blacks and Hispanics had worse predisposed illness prior to the pandemic due to a variety of social determinants of health, increased infection rate due to overrepresentation in high-risk living situations/jobs, and all of this has resulted in disparities in COVID infection and death. These were then further aggravated by the laws imposed on them as a result of their occupations, their relationships, interactions with individuals in the workplace and at home, prison and homeless camps included, and the stereotypes and distrust promoted by the healthcare industry. Their inability to fight against these social structures was a catalyst in allowing these minority groups to be affected disproportionately.